Part 4 of this webinar, Hypertension, Diagnosis and Management 2021, is a project of the Utah Million Hearts Coalition, sponsored by the U.S. Centers for Disease Control and composed of multiple healthcare organizations throughout the state of Utah. We will review interventions to improve blood pressure control, including lifestyle and pharmacologic therapy and team-based care. Continuing medical education credits are available for completing this webinar. Please watch parts 1 to 4 and complete the evaluation in the description below to be eligible for these credits. The Centers for Disease Control Million Hearts Initiative 2017 to 2022 predicts there will be 16 million cardiovascular disease events in the United States between 2017 and 2022. And as its goal, hopes to prevent 1 million of these cardiovascular disease events by the year 2022. A key component of this initiative is to attain an 80% or greater hypertension control rate below 140/90. But the ugly truth in 2017-2018, the most recent year for which we have accurate hypertension control rate data, is that only 44% of U.S. hypertensive persons were controlled below 140/90, compared to 54% in 2013-2014, and only 19% were controlled below 130/80 millimeters of mercury, the new blood pressure target set by the American College of Cardiology American Heart Association in late 2017. Additionally, hypertension-related mortality has also increased from 2011 through 2018 in persons aged 55 and older. The goal of this webinar is to provide guidance to help achieve an 80% hypertension control rate below 140/90 and at least a 50% control rate below 130/80 by the year 2022. The objectives of Part 4 of this webinar are to provide evidence-based recommendations for lifestyle therapy, pharmacologic therapy, team-based care, and patient self-management. The 2017 ACC-AHA recommendations for lifestyle and pharmacologic therapy are summarized on this slide. Patients with the new classification of, quote, elevated blood pressure, 120/129 over less than 80 millimeters of mercury, should, in most cases, receive only lifestyle therapy. Patients with the new stage 1 hypertension, blood pressure 130/139 over 80-89 millimeters of mercury, are subdivided into those with a less than 10% or a 10% or higher 10-year cardiovascular risk as calculated by the pooled cohort equation. About 69% of stage 1 patients have a less than 10% 10-year cardiovascular risk and are therefore treated only with lifestyle therapy and ongoing follow-up. On the other hand, stage 1 patients with a blood pressure 130/139 over 80-89 and clinical cardiovascular disease, or a prior lacunar stroke, or diabetes, or chronic kidney disease, or age 65 and over and ambulatory and living in the community, or with a 10-year cardiovascular risk of 10% or higher as calculated by the pooled cohort equation, initially should receive both lifestyle and pharmacologic therapy, as do stage 2 hypertension patients with blood pressure 140/90 and higher. Follow-up with adjustment of therapy as needed at 1-month intervals is recommended until home blood pressure is controlled below 130/80 in both the office and out of the office. However, threshold and target blood pressure levels may be adjusted upward for patients with limited lifespan or severe comorbidities. Step 7, lifestyle modification, and remember that steps 1 through 6 are listed on the previous versions of this talk, involves selection of one or more interventions to lower blood pressure according to need and individual patient motivation and desire to use that particular lifestyle modification. Blood pressure reductions achieved in studies are listed for the DASH diet, 11/5 millimeter of mercury reduction, diet sodium reduction by 1.8 grams per day from baseline, a 5/3 millimeter reduction, exercise of 30 to 60 minutes a day, a 3 to 8 over 2 to 5 millimeter reduction, weight loss, a reduction of 1/1 millimeter of mercury per kilogram of weight loss, and reduction in heavy alcohol, a 3 to 6 over 3 to 4 millimeter reduction. In real-world situations, with proper prescription and patient adherence to the lifestyle interventions, a blood pressure reduction over 7/5 millimeters of mercury has been documented in private practice settings. And this blood pressure reduction is equivalent to a low dose of an antihypertensive medication. However, practice-based studies have found that a minority of patients change their lifestyle after a diagnosis of hypertension. And of those who do, few sustain it beyond 1 year. For that reason, a 3 to 6 month trial of lifestyle modification as the only intervention to lower blood pressure is recommended only for stage 1 hypertension patients with a blood pressure of 130 to 139 over 80 to 89, whose 10-year cardiovascular risk is less than 10%. Stage 1 hypertension patients with a 10-year cardiovascular risk of 10% or higher, and stage 2 hypertension patients should all have simultaneous lifestyle modification and pharmacologic therapy. Recent studies have reviewed the possible role of potassium supplementation to lower blood pressure. Current recommendations for daily potassium intake for men are 3.4 grams or 46 milliequivalents or higher, and for women, 2.6 grams, 34 milliequivalents or higher, while current U.S. mean daily intake is just 2.6 grams. A recent meta-analysis of 22 randomized clinical trials with 1,892 participants found that providing an additional 1.2 grams of potassium up to 7 grams of potassium, that is 16 to 91 milliequivalents per day, of either dietary potassium or even oral potassium chloride reduced systolic blood pressure by 5 to 6 millimeters of mercury. Current potassium supplementation recommendations favor the use of fruits and vegetables rather than oral potassium chloride or salt substitutes. However, there should be caution with or avoidance of potassium supplementation in patients with an estimated glomerular filtration rate below 60 mLs per minute or who have serum potassium levels of 4.5 milliequivalents per liter or higher, especially if such patients are on inhibitor medications of the renin-angiotensin-aldosterone system or are on a trimethoprim sulfa antibiotic. For most eligible hypertension patients, at least 2 servings of fruits and vegetables a day, that is 1.2 grams or 16 milliequivalents of potassium, and for African Americans, 3 servings, 1,800 milligrams or 24 milliequivalents per day are recommended. The use of salt substitutes and potassium-enriched table salt is currently under investigation. Note that the DASH diet, which has been shown to lower blood pressure by 11/5 millimeters of mercury in hypertensive patients, includes 8 to 9 servings of fruits and vegetables per day. Unfortunately, as we have said before, lifestyle therapy to lower blood pressure is not used effectively by most persons in the United States. Data from the National Health and Nutrition Examination Survey indicate that from 1999 to 2012, there was actually significant deterioration in dietary sodium restriction, deterioration in implementation of the DASH diet, a significant increase in overweight and obesity status, and no improvement in physical activity or heavy alcohol intake among Americans. For Step 8, pharmacologic therapy, the approach recommended by the 2017 ACC-AHA Hypertension Guideline is summarized on this slide. Once the diagnosis of hypertension has been confirmed with out-of-office blood pressure monitoring and important orthostatic hypotension, a standing systolic blood pressure below 110 millimeters of mercury has been detected, patients with stage 1 hypertension, 130 to 139 over 80 to 89 millimeters of mercury, and a 10-year cardiovascular risk of 10% or higher, or in one of the other higher risk subgroups listed on previous slides, should receive initial monotherapy with a single drug. For African American patients, monotherapy with a diuretic or calcium channel blocker is favored due to greater blood pressure reduction for African Americans than they will have with an ACE inhibitor or an angiotensin receptor blocker, unless there is a compelling indication to use renin-angiotensin-aldosterone inhibition. Non-African American patients may receive monotherapy with a diuretic, calcium blocker, ACE inhibitor, or angiotensin receptor blocker. There is some evidence that persons aged 55 to 65 and younger may have a slightly greater blood pressure reduction with an ACE inhibitor or angiotensin receptor blocker, while older patients may have a slightly greater blood pressure reduction with a diuretic or calcium channel blocker. Beta blockers should be used as initial therapy only if there is a compelling indication, due to beta blocker having a lesser ability to prevent stroke than the other drug classes. On the other hand, for patients with a baseline blood pressure of 150 over 90 or higher, and for most patients with baseline blood pressure 140 over 90 or higher, initial low-dose 2-drug therapy is recommended, combining an ACE inhibitor or angiotensin receptor blocker with a calcium channel blocker, particularly in patients at high risk of cardiovascular disease or with gout, or alternatively, combining an ACE inhibitor or angiotensin receptor blocker with a thiazide-like or thiazide-type diuretic. Fixed-dose combination medications are favored if available and affordable. However, there should be caution and probably initial low-dose 1-drug therapy only in very elderly or frail patients, in patients with a significant orthostatic blood pressure drop of 20 over 10 millimeters of mercury or higher, or in patients with multiple medication intolerances. Although in the absence of a compelling indication, beta blocker medications are not favored as initial antihypertensive therapy, these medications do reduce cardiovascular disease events in hypertension patients. A 2020 meta-analysis of 5 randomized clinical trials with 18,724 participants found that an average 10.5 over 7.0 millimeter of mercury blood pressure reduction over 5 years, beta blockers reduce cardiovascular events by 22%, including a 43% reduction in hospitalized heart failure and 23% reduction in stroke. Note that the 12% reduction in coronary heart disease events in this meta-analysis was not quite statistically significant. However, beta blockers do not appear to be as effective as calcium channel blockers, ACE inhibitors, angiotensin receptor blockers, or diuretics to reduce cardiorenal events. A meta-analysis of 123 randomized trials with 613,815 patients found that beta blockers were associated with 17% more cardiovascular events, 24% more strokes, and 19% more renal failure than the other major blood pressure drug classes. So beta blockers are usually considered as a step 4 or step 5 drug, unless there is a compelling indication to use them earlier during therapy. What are the best diuretics to use in hypertension patients? Thiazide-like diuretics, such as indapamide and chlorthalidone, are superior to thiazide-type diuretics, such as hydrochlorothiazide and others, which in turn are superior to loop diuretics, such as furosemide, bumetanide, and torsemide for lowering blood pressure. Indapamide and chlorthalidone have longer durations of action, greater than 24 hours for indapamide and 48 to 72 hours for chlorthalidone, than hydrochlorothiazide with its 16 to 24-hour half-life. Indapamide at a dose of 1.25 milligrams daily and chlorthalidone at a dose of 12.5 milligrams daily lower systolic blood pressure about 5 millimeters of mercury more than hydrochlorothiazide at a dose of 25 milligrams daily. Chlorthalidone at a dose of 25 milligrams daily lowers 24-hour ambulatory systolic blood pressure about 5 millimeters of mercury more than hydrochlorothiazide at a dose of 50 milligrams daily, and it lowers nighttime blood pressure about 7 millimeters of mercury more. Indapamide may have lesser effects on potassium, sodium, glucose, and lipids than either chlorthalidone or hydrochlorothiazide. On the other hand, indapamide and hydrochlorothiazide are considerably less expensive than chlorthalidone. Hydrochlorothiazide does have the advantage over the other two diuretics in its availability in multiple single-pill fixed-dose combinations. Note that a recent observational study noted a possible association of hydrochlorothiazide with non-melanoma skin cancer that did not appear with the other two medications, indapamide and chlorthalidone. Although there are no head-to-head randomized trials for clinical events comparing indapamide and chlorthalidone with hydrochlorothiazide, network meta-analyses of randomized clinical trials compared to placebo and adjusted for blood pressure reduction suggest that indapamide and chlorthalidone may reduce cardiovascular events, total mortality, and left ventricular mass 12 to 14% better than hydrochlorothiazide. The multiple guidelines listed on this slide now favor indapamide and chlorthalidone over hydrochlorothiazide. Although the excellent availability of hydrochlorothiazide in single-pill fixed-dose combinations must be considered. So, the best diuretic for hypertension therapy may therefore depend on several factors. For patients with a GFR 30 mLs per minute or greater, if efficacy to lower blood pressure and cardiovascular disease prevention are key, as they would be in patients especially at high cardiovascular risk, indapamide and chlorthalidone are excellent choices. For patients at lower cardiovascular risk, where convenience and adherence are issues, hydrochlorothiazide in a single pill fixed-dose combination may be considered. In contrast, in patients with thiazide-induced hyponatremia or with estimated glomerular filtration rate below 30 mLs per minute, the long-acting once-daily loop diuretic torsemide may be a better diuretic choice. Most patients with a GFR below 30 mLs per minute have excess sodium retention and high total body volume. In these patients, effective blood pressure lowering may require titration of the torsemide dose to accomplish a 3 to 4 pound weight loss, but with close monitoring of the blood potassium and creatinine levels. The short-acting loop diuretics, furosemide and bumetanide, must be given twice daily to effectively lower blood pressure, and so are impractical for most patients. Still, there are some recent small randomized clinical trials suggesting that chlorthalidone at a dose of 25 to 50 milligrams a day may be able to lower blood pressure in patients with a GFR below 30 mLs per minute. In most current hypertension guidelines, initial low-dose 2-drug therapy is favored for many patients whose initial baseline blood pressure is 140 over 90 millimeters of mercury or higher. There are several rationales for this recommendation. First, 75% or more of hypertension patients require 2 or more drugs to achieve blood pressure control below 140 over 90 millimeters of mercury, let alone to a target blood pressure below 130 over 80 millimeters of mercury. A second rationale, initial low-dose 2-drug therapy appears to be more effective, more efficient, and more tolerable than maximal dose monotherapy. Randomized clinical trials comparing initial low-dose 2-drug therapy to initial 1-drug therapy have demonstrated 26 to 39% greater blood pressure reduction at 6 weeks to 6 months, and 20% greater hypertension control rates at 3 to 12 months. These benefits may be due to several factors. First, a decrease in clinician therapeutic inertia to intensify antihypertensive therapy over time. Second, 2-drug therapy may correct for the variability in individual response to any single class of antihypertensive drug. And third, because of an absolute 10 to 21% improvement in patient medication adherence due to lower pill burden. Observational studies have also found a 10 to 34% reduction in cardiovascular disease events after 1 to 2 years, and a 20% reduction in mortality after 3 years using initial low-dose 2-drug therapy. Presumably, this is due to better blood pressure control. Initial low-dose 2-drug therapy potentially may also decrease costs, as it provides a greater early blood pressure reduction than 1-drug monotherapy, resulting in the need for fewer drug titrations and office visits. Single pill combinations may save a copay on some insurance policies, but only a few single pill combinations are less expensive than prescribing the 2 or 3 individual components separately. As demonstrated on this slide, compared to a maximal dose of 1 blood pressure drug, initial low-dose 2-drug therapy provides greater blood pressure reduction and therefore requires fewer drug titrations. Because side effects for most blood pressure drugs are directly proportional to dose, except for the cough caused by ACE inhibitors, initial low-dose 2-drug therapy also results in fewer side effects than a maximal dose of 1 drug. Meta-analyses of dose-response studies have found that on average, the standard dose of any blood pressure drug, which we'll show you on the next slide, lowers blood pressure about 9 over 5 millimeters of mercury from a baseline blood pressure of 150 over 95. However, 1 blood pressure medication at just 1/4 standard dose already lowers blood pressure 5 over 3 millimeters of mercury. And 2 drugs at 1/4 standard dose or 1 drug at half standard dose lower blood pressure by 7 over 4 millimeters of mercury. In contrast, doubling the standard dose of 1 drug reduces blood pressure only by an additional 2 over 2 millimeters of mercury. However, using 2 drugs at half standard dose lowers blood pressure by 14 over 8 millimeters of mercury. Using 3 drugs at half standard dose lowers blood pressure by 29 over 14 millimeters of mercury. And using 4 drugs at quarter standard dose lowers blood pressure by 22 to 24 over 11 to 13 millimeters of mercury. This slide shows the standard doses for different blood pressure drugs to lower blood pressure by a mean 9.5 over millimeters of mercury from a baseline of 150 over 95, and includes a variety of diuretics, ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and beta blockers. However, note that any particular individual's blood pressure response to a given drug may vary markedly from this average due to different mechanisms for hypertension in different individual patients. Are single-pill two-drug combination blood pressure drugs more effective than giving the same two drugs at the same doses, but as two separate medications? Randomized clinical trials up to 1 year in duration indicate that systolic blood pressure reductions are similar, although longer duration studies suggest a marginal 2.5 millimeter systolic blood pressure reduction favoring the single-pill combinations. Real-world cohort studies suggest 13 to 28% better adherence to single-pill combinations than using two separate drugs, and one cohort study found an 11% reduction in cardiovascular mortality after 5 years with single-pill combinations. Unfortunately, some single-pill combinations of 2 and 3 blood pressure medications are prohibitively expensive for some patients. There are limitations to the conclusions of these studies, and more data are needed. Currently, there are some important limitations with single-pill fixed-dose combination blood pressure medications. First, single-pill fixed-dose combinations are prescribed to only 14 to 23% of U.S. hypertensive patients in studies from 2005 to 2016. Available single-pill fixed-dose combinations often do not include desired drug combinations. Most are two-drug combinations. There are only 2 3-drug combinations, and there are no 4-drug combinations. There are only 2 combinations with chlorthalidone and none with indapamide. There are many with low-dose but less effective hydrochlorothiazide. There is only 1 combination with spironolactone for resistant hypertension patients. There are no calcium channel blocker thiazide-diuretic combinations, which have recently been shown to be very effective in Black patients. There are also important cost issues, as insurance coverage for single-pill fixed-dose combinations has been unpredictable. About 70% of the time, using 2 separate medications is less expensive than using the equivalent single-pill fixed-dose combinations, with a few exceptions as noted on the slide. When selecting initial pharmacologic therapy, consideration should first be given to pregnancy potential and to any compelling indications to use a specific blood pressure drug. For women with pregnancy potential, ACEs and ARBs have teratogenic effects and should generally be avoided unless there is a compelling indication and excellent birth control is in place. A baseline pregnancy test should be strongly considered if either ACE inhibitors or ARBs are used. Dihydropyridine calcium channel blockers, for example, nifedipine extended release or amlodipine, are good initial choices for women with pregnancy potential, followed by labetalol or another beta blocker if necessary, and then by a thiazide-like or thiazide-type diuretic if needed as a third drug. For women planning pregnancy, extended-release nifedipine, labetalol, and alpha-methyl-dopa are favored. During lactation, extended-release nifedipine, enalapril, again with excellent birth control in place, labetalol, and alpha-methyl-dopa are favored. Atenolol and propranolol, which cross over into breast milk, should be avoided. There are some compelling indications to use specific blood pressure lowering drugs. Patients with diabetes or chronic kidney disease who have major albuminuria, defined as an albumin-creatinine ratio of 300 milligrams per gram or more, require an ACE inhibitor or ARB if tolerated, and one of these 2 drugs may also be favored for lesser degrees of albuminuria, defined as an albumin-creatinine ratio of 30 to 299 milligrams per gram. In the absence of albuminuria, ACE inhibitors and ARBs do not provide special renal protection beyond that of other blood pressure drugs. For patients with recent myocardial infarction or systolic heart failure, the combination of an ACE or an ARB and a beta blocker And in systolic heart failure patients, the further addition of a mineralocorticoid receptor antagonist such as spironolactone or eplerenone is preferred. Patients with stable coronary artery disease may receive an ACE inhibitor or an ARB, and in the presence of stable angina, the addition of a beta blocker or calcium channel blocker if needed. In paroxysmal atrial fibrillation patients, an ARB may help to reduce recurrences. Beta blockers are favored in patients with thoracic aortic aneurysms. In asthma patients, ARBs are favored over ACE inhibitors, and beta blockers should be limited to patients with a compelling indication. In patients with gout, there is evidence that losartan and amlodipine may lower uric acid blood levels, while thiazide and thiazide-like diuretics increase uric acid blood levels and may precipitate a gout flare. Patients on HIV medications may experience drug interactions with some calcium channel blockers, particularly verapamil and diltiazem, and consultation with the treating HIV specialist should be sought before using them. Newly recognized are compelling indications or contraindications for specific blood pressure medications in hypertension patients with cancer. It is now apparent that the prevalence of hypertension is substantially increased in patients with cancer. 1/3 of cancer patients will have new onset hypertension after their diagnosis at a median time of 3 months. More than 70% of childhood cancer survivors will develop hypertension by age 50, several-fold higher than the prevalence in the general population. Multiple chemotherapeutic agents, as listed on the slide, are now associated with either new or increased hypertension, while radiation to the abdomen, as is accomplished for some lymphoma patients, can result in renal artery stenosis many years later, and head and neck radiation can cause carotid baroreceptor dysfunction with widely fluctuating blood pressure from high to low. Newly recognized are compelling indications or contraindications for specific blood pressure medications in hypertension patients with cancer. It is now apparent that the prevalence of hypertension is substantially increased in patients with cancer. 1/3 of cancer patients will have new onset hypertension after their diagnosis at a median time of 3 months. More than 70% of childhood cancer survivors will develop hypertension by age 50, a prevalence several-fold higher than in the general population. Multiple chemotherapeutic agents, as listed on the slide, are now associated with either new or increased hypertension, while radiation to the abdomen can result in renal artery stenosis and hypertension many years later. Head and neck radiation can cause carotid baroreceptor dysfunction with widely fluctuating blood pressure levels from high to low. This slide shows a recently published algorithm to guide blood pressure selection in patients with concurrent cancer. As in all hypertension patients, out-of-office blood pressure monitoring is essential to confirm a hypertension diagnosis, and serial home blood pressure monitoring is needed to guide blood pressure medication titration. Specifically note that verapamil and diltiazem should not be used due to their frequent drug interactions with multiple chemotherapeutic agents. Diuretic therapy should generally be used only as the third agent when necessary, as many of these patients will be subject to intermittent volume depletion, for example, from nausea and/or vomiting. In the presence of heavy albuminuria, defined as greater than 300 milligrams per gram of creatinine, an ACE inhibitor or angiotensin receptor blocker is favored as initial therapy, followed by a dihydropyridine calcium channel blocker, and vice versa for patients without heavy albuminuria. Diuretics may be used as the third drug, with mineralocorticoid receptor antagonists or vasodilating beta blockers as the fourth drug. In the general population of patients who do not have pregnancy potential or a compelling indication for a specific antihypertensive medication, the most desirable two-drug regimens are those supported by randomized clinical trials showing both additive blood pressure lowering and a reduction in cardiovascular events. Such combinations include an ACE inhibitor or possibly an angiotensin receptor blocker with a calcium channel blocker such as amlodipine, a thiazide diuretic with an ACE inhibitor or angiotensin receptor blocker, and in Black patients, a calcium channel blocker and thiazide diuretic, as was recently demonstrated in the recent CREOLE randomized trial of Black patients. The combination of a thiazide diuretic and a beta blocker provides lesser cardiovascular disease event reduction than the other regimens listed above, and is more likely to precipitate or aggravate diabetes mellitus. An ACE inhibitor or angiotensin receptor blocker with a beta blocker does not usually provide additive blood pressure lowering, although it is an optimal combination for patients with systolic heart failure or who are post-myocardial infarction in the first 1 to 3 years. The combination of a dihydropyridine calcium channel blocker and a beta blocker does additively lower blood pressure, but its effects on cardiovascular disease events have not been studied in a randomized trial. 2 drug combinations that should be avoided include an ACE inhibitor with an angiotensin receptor blocker, as this provides no additional cardiorenal benefit but does provide greater side effects, clonidine with beta blockers because of bradycardia and rebound hypertension if there is abrupt discontinuation of clonidine, and non-dihydropyridine calcium channel blockers such as verapamil and diltiazem in combination with beta blockers because of bradycardia. A meta-analysis of 8 randomized trials with 20,451 patients found that the optimal 2-drug regimen, at least in patients at relatively high cardiovascular disease risk, is an ACE inhibitor or angiotensin receptor blocker with a calcium channel blocker, with amlodipine being the calcium channel blocker most often studied. Compared to other combinations, such as an ACE inhibitor or angiotensin receptor blocker with a diuretic, or a beta blocker combined with a dihydropyridine calcium channel blocker, or a beta blocker combined with a thiazide diuretic, this combination reduced cardiovascular disease events, reduced progression of chronic kidney disease, and reduced adverse drug events to a greater extent. And there was also a trend in this meta-analysis toward a reduction in total mortality. There is less evidence about the optimal 3-drug regimen in the general population. However, the combination of an ACE inhibitor or angiotensin receptor blocker with a calcium channel blocker and with a thiazide diuretic does provide additive blood pressure reduction, does reduce the side effects of diuretic-induced hypokalemia and calcium channel blocker-induced peripheral edema, and at least in the post-hoc analysis of the ADVANCE randomized clinical trial, did reduce cardiovascular events to a greater extent than other 3-drug regimens. However, a confirmatory randomized clinical trial would be desirable to confirm these events. The availability of less expensive 3-drug single combinations is particularly desirable. At what intervals should blood pressure drugs be titrated to lower blood pressure to goal? A meta-analysis of 18 randomized trials with 4,168 patients found that 50% of maximal blood pressure reduction was accomplished at 1 week, 75% at 2 weeks, and 100% at 4 weeks after either medication initiation or adjustment. Another study of 2,990 patients followed for 24 months found that hypertension control rates were optimized when blood pressure titration visits occurred at intervals of 2 to 4 weeks, compared to longer titration intervals ranging from 2 to 6 months. Finally, a study linking hypertension control to mortality in 18,721 patients followed for 5.4 years found that in hypertensive patients over age 60 years, Failure to control blood pressure to goal within 90 days increased total mortality by 15%. So optimally, patients should have their blood pressure controlled within 3 months with adjustment of blood pressure medications every 2 to 4 weeks until blood pressure is at goal for 2 successive visits, with subsequent follow-up at 6-month intervals. The 2017 American College of Cardiology, American Heart Association Hypertension Guideline favors titrating blood pressure medications according to the average of 12 to 24 accurately measured home blood pressure readings obtained over a period of 3 to 7 days. When target office blood pressure is below 130 over 80 millimeters of mercury, target home blood pressure is also below 130 over 80 millimeters of mercury. In contrast, when target office blood pressure is below 140 over 90 millimeters of mercury, target home blood pressure is below 135 over 85 millimeters of mercury. Patients with uncontrolled hypertension on an optimal 3-drug regimen, including a maximally tolerated dose of an ACE inhibitor or angiotensin receptor blocker, a calcium channel blocker, and a diuretic appropriate to the estimated glomerular filtration rate, are considered to have, in quotes, apparent resistant hypertension, end quote. Clinicians should check to see if patients are on some other suboptimal 3-drug regimen. They should change any hydrochlorothiazide used to the more effective chlorthalidone or indapamide. They should consider changing to a single pill, 2 or 3 drug combination pill when possible. They should confirm with out-of-office blood pressure monitoring that patients do not have white coat resistant hypertension, which is present in 30% of resistant hypertension patients. They should also check for medication non-adherence, which is present in at least 30% of these patients. They should check for other drugs that may increase blood pressure, such as nonsteroidal anti-inflammatory medications, estrogens, epogens, heavy alcohol use, and a variety of others. And they should review and consider testing and/or referring the patient to a hypertension specialist to evaluate possible secondary causes of hypertension. The optimal 4th antihypertensive drug has recently been investigated. The 2015 Pathway 2 randomized clinical trial of 285 patients with uncontrolled hypertension on home blood pressure monitoring, despite a 3-drug regimen of an ACE inhibitor or angiotensin receptor blocker, a calcium channel blocker, and a diuretic, found that spironolactone was the optimal 4th drug to lower blood pressure in 60% of patients. However, doxazosin or a beta blocker were the optimal 4th drugs in each of 20% of patients. Note that to enter this trial, estimated glomerular filtration rate had to be 45 mLs per minute or higher to minimize the incidence of serious hyperkalemia, which was 2% in patients treated with spironolactone. Also note that the efficacy of spironolactone was inversely proportional to plasma renin activity, such that some patients with low plasma renin had a greater than 20 millimeter reduction in home systolic blood pressure when spironolactone was added to the therapeutic regimen. A recommended approach to patients with resistant hypertension on the optimal maximal tolerated 3-drug regimen listed on the slide that has been confirmed in the out-of-office setting and who have apparent good medication adherence is summarized on this slide. The first step is to check estimated glomerular filtration rate and serum potassium. And if the eGFR is 45 mLs per minute or higher, and the serum potassium is less than 4.5 milliequivalents per liter, respectively, initiate spironolactone at a dose of 12.5 to 25 milligrams daily, with follow-up of serum potassium and creatinine at 1 and again at 4 weeks. Amiloride at a dose of 10 to 20 milligrams daily, or eplerenone at a dose of 50 milligrams once or twice daily, may be substituted for spironolactone in the event of side effects from spironolactone. If eGFR instead is below 45 mLs per minute, or serum potassium is 4.5 milliequivalents per liter or higher, review the patient's usual heart rate. If the heart rate is generally higher than 84 to 90 beats per minute, a beta blocker is a reasonable choice as the fourth blood pressure drug, as it may provide additive blood pressure lowering in the setting of the relatively high heart rate. If instead estimated glomerular filtration rate is below 45 mLs per minute, or serum potassium is 4.5 milliequivalents per liter or higher, but the heart rate is below 84 to 90 beats per minute, doxazosine at bedtime is a reasonable fourth drug choice. Another option is to add extended-release diltiazem to amlodipine, although 20% of such patients may develop peripheral edema. Medication non-adherence is a major contributor to inadequate hypertension control rates, as noted in the 3 comments on this slide. The full benefits of medications cannot be realized at currently achievable levels of adherence, or perhaps more bluntly, drugs don't work in patients who don't take them, and medication non-adherence may be an intrinsic property of human beings. A 2019 study of 24 million U.S. hypertensive patients found that 31% were non-adherent to their blood pressure medications, defined as not having obtained enough refills to take at least 80% of their medications. This 80% refill percentage, below which blood pressure has been shown to increase substantially. As indicated on the slide, non-adherence rates were highest in Medicaid patients, in women under age 64 compared to men under age 64, and in both sexes, age 65 and over, and in patients under age 55, especially in patients under age 45, where more than half of patients were non-adherent. This same study found that non-adherence was lowest with angiotensin receptor blockers and ACE inhibitors, and higher with beta blockers, calcium channel blockers, and especially with diuretics. Non-adherence was even higher with other second-line antihypertensive medications. Patients may have suboptimal adherence to blood pressure medications with respect to initiation of therapy, implementation, that is, taking as prescribed therapy, and subsequent discontinuation of therapy. Medication non-adherence is a major contributor to low hypertension control rates. 26 to 28% of hypertension patients do not fill their initial medication prescription. 32 to 40% of hypertension patients take less than 80% of their prescribed blood pressure medication doses. 21 to 24% of patients discontinue blood pressure medication by the end of the first year. Older patients, age 65 and over, appear to have slightly better adherence with respect to implementation and discontinuation at 1 year than younger patients. Overall, some form of suboptimal adherence appears to be the rule rather than the exception for antihypertensive therapy. Suboptimal medication adherence in hypertension has substantial adverse consequences. A cohort study of 160,000 hypertensive Medicare patients, followed for 6 years, found that patients with low and intermediate implementation adherence, taking less than 80% of their prescribed doses, had a rate of nearly 10% major cardiovascular disease events per year, while the rate in high adherence patients was 56% lower at 4% per year. Current estimates are that at least 10% of all cardiovascular events in the United States are secondary to non-adherence to cardiovascular medications, costing the country $18.5 billion per year. Unfortunately, it is quite difficult to detect medication non-adherence. Clinician interview detects less than 25% of non-adherence with an accuracy below 50%. But over 60% of clinicians never even ask about hypertension medication adherence. Self-report questionnaires, such as the Mariski scale, do only a little better, detecting 25 to 35% of low blood pressure medication adherence. Pill counts are better, but are obviously too strenuous in primary care settings. Review of prescription refills to detect patients who have less than 80% of the medication required for daily intake is better, but is not always easily available. The recent utilization of serum and urine blood pressure medication assays detects a great deal of non-adherence. Nearly 50% of patients with resistant hypertension had undetectable levels of blood pressure medications in their serum and/or urine in multiple studies. But how to ethically and comfortably use these assays in the real world is uncertain, and availability of these assays is relatively limited. There are similar concerns with the approach of having patients take their blood pressure medications under direct observation in the clinic, followed by a 24-hour ambulatory blood pressure monitor study, an approach that has found 45% of resistant hypertension patients to be non-adherent to their blood pressure medications. While it is very difficult to detect suboptimal blood pressure medication adherence, it may be even more difficult to improve it, as noted in these recent reviews. Today, little evidence exists that drug adherence can be consistently improved within the resources usually available, and current methods of improving medication adherence are mostly complex and not very effective. Still, it is important that we make our best effort to improve hypertension medication adherence. There is some evidence that a better overall patient experience may improve hypertension medication adherence. Informing patients with both verbal and written materials, and one can see the website www.targetbloodpressure.org for excellent patient education tools, about hypertension risks and treatment benefits and side effects using a shared decision-making approach, and identifying potential adherence barriers, such as using the question, "Do you have any concerns with this plan?" may be helpful to improve adherence. Approaching hypertension management by identifying financial barriers and using generic, low-cost drugs that can be given once daily rather than twice daily, and using single pill combination drugs when their expense is feasible for patients, all may improve adherence some. However, only 14 to 23% of U.S. hypertension patients currently use single pill combination medications. As side effects are generally directly proportional to dose, using low-dose combinations of multiple medications may be better tolerated as well as more effective than using maximal doses of one or two medications. There may be some trade-off with overall pill burden unless single pill combinations can be used. Several studies have found improvement in adherence by providing 90-day medication supplies rather than 30-day medication supplies, using mail-order refills, and being sure that all medications are refilled at the same time. As noted previously, multiple studies have shown that the one-year persistent to blood pressure drugs is highest with angiotensin receptor blockers, lowest with diuretics, with ACE inhibitors and calcium channel blockers in between when using the four major drug classes. These two studies looked at blood pressure medication utilization, persistence at 1 year, and cost per year in 2014-2015. ACE inhibitors and thiazide diuretics had the greatest utilization by clinicians and angiotensin receptor blockers the lowest utilization by clinicians, perhaps because annual costs were lowest for ACE inhibitors and thiazide diuretics, but highest for angiotensin receptor blockers. Note that beta blocker utilization appears to be higher than recommended in current hypertension guidelines. But 1-year persistence was highest for angiotensin receptor blockers and lowest for thiazide diuretics. More research is needed on how to balance long-term persistence to blood pressure medications with the cost of these blood pressure medications. An important contributor to non-adherence to hypertension medications in men is erectile dysfunction. Too little is known currently about female sexual dysfunction in hypertension and with hypertension medications. The prevalence of erectile dysfunction in men is 15 to 20% in the general population, 30 to 40% in hypertension patients, and may increase further with hypertension therapy. 50 to 60% of patients with cardiovascular disease and hypertension have erectile dysfunction. The significance of erectile dysfunction in hypertension is twofold. First, erectile dysfunction is an independent cardiovascular risk factor, increasing the risk of future cardiovascular events by 44%, because erectile dysfunction is actually a marker of systemic atherosclerotic vascular disease. But second, erectile dysfunction has been documented to reduce blood pressure medication adherence. Erectile dysfunction has been improved in randomized clinical trials by non-pharmacologic therapy, such as weight loss, exercise, smoking cessation, and alcohol restriction, and has been improved by the use of PDE5 inhibitor medications, such as Viagra and Cialis. The utilization of these PDE5 inhibitors has actually been shown to improve blood pressure medication adherence. Importantly, erectile dysfunction may also be improved by changes in the blood pressure medication regimen as discussed on the next slide. A recent 2020 review by the European Society of Hypertension found an increase in erectile dysfunction with most beta blockers, most thiazide diuretics, mineralocorticoid receptor antagonists such as spironolactone, and central alpha agonists including clonidine and guanfacine. ACE inhibitors, calcium channel blockers, indapamide, amiloride, and alpha blockers appear to have no effects on erectile dysfunction. An actual decrease in erectile dysfunction has been reported with angiotensin receptor blockers and with the vasodilator beta blocker nebivolol. Nebivolol is known to increase vasodilating nitric oxide similar to the PDE5 inhibitors. So, adjusting the selection of antihypertensive medications may help to reduce the prevalence of erectile dysfunction in hypertension patients. Blood pressure medication adherence may also be improved by more comprehensive follow-up. Seeing patients every 2 to 4 weeks until blood pressure is controlled, by initiating home blood pressure monitoring with clinic support, and by assessing adherence at each follow-up visit in non-judgmental fashion. For example, asking patients, "It is difficult to remember to take medications daily. How do you manage?" And finally, initiating a team care approach for clinic hypertension management. Therapeutic clinician inertia, defined as when clinicians fail to increase the dose or the number of blood pressure medications when it is appropriate to do so, is also an important contributor to low hypertension control rates. A 2016 National Health and Nutrition Examination Survey study found that 40% of U.S. hypertension patients with blood pressure 140 over 90 millimeters of mercury or higher were taking only a single blood pressure medication. While a 2012 National Ambulatory Medical Care Survey found that clinicians intensified hypertension therapy on only 17% of visits when blood pressure was high above goal. While on some occasions, failure to intensify hypertension therapy in the office represents appropriate inaction, for example, the patient's out-of-office blood pressure is at goal, or the patient refuses therapy intensification, or medication adherence is shown to be inadequate, or patient iatrogenic risk and comorbidity favors a higher blood pressure goal. However, in most cases, failure to intensify therapy appears to represent inappropriate therapeutic inertia. Where out-of-office blood pressure is high or unknown, adherence is presumed to be good, but the patient is still not at the desired blood pressure goal. The goal of team-based care is to organize the swamp of daily clinical practice to reduce therapeutic clinician inertia, improve clinic efficiency, and to improve the patient experience. Different team members share the responsibility for accomplishing the multiple tasks of overall hypertension management. For example, medical assistants can provide accurate blood pressure measurement and home blood pressure measurement training. Clinical pharmacists or nurses, when in the scope of their practice, can carry out algorithm-guided drug titration. Some or all of the team may provide health coaching for the patient, and the electronic medical record can be adjusted by informatics staff to facilitate decision support and home blood pressure monitoring. Multiple studies have found team care to effectively lower blood pressure and to be cost-effective. A systematic review and meta-analysis of 100 studies with 55,920 patients found that the key component of team-based care for hypertension management may be algorithm-guided drug titration by clinical pharmacists or nurses when in the scope of their practice, thereby reducing clinician therapeutic inertia and lowering blood pressure by an average of 7 millimeters of mercury in 10 studies. Regular drug titration by clinicians, health coaching, and some form of EMR decision support also have been shown to lower blood pressure by 4 to 6 millimeters of mercury. As noted on the previous slide, one team care approach has been demonstrated to improve hypertension control rates. Using such an approach, Kaiser Permanente, Northern California, improved their hypertension control rate below 140 over 90 millimeters of mercury from 44% in 2001 to 90% in 2013. They provided new team roles for existing staff, and they added the services of a clinical pharmacist as new staff. On the left side of this slide, you can see that they first identified patients in their clinics who had uncontrolled hypertension, initially with a paper registry and later with an EMR registry, and they called these patients back to clinic for blood pressure review. They also improved the accuracy of office blood pressure measurement by switching from manual to electronic measurement. But as we have seen earlier in this discussion, providing unattended AOBP to patients with an elevated observed blood pressure can even better reduce white coat blood pressure elevation and improve clinic hypertension control rates. Kaiser Permanente reduced clinician therapeutic inertia by using initial low-dose 2-drug therapy for most hypertension patients, rather than initial 1-drug therapy, and they used algorithm-guided therapy with serial titration of medications every 2 to 4 weeks until blood pressure was controlled. And this was often managed by either a clinical pharmacist or a registered nurse. They also selected optimal 3 and 4 drug therapeutic regimens. As we have seen in the prior discussion, addition of an effective home blood pressure monitoring program can also contribute to improved hypertension control rates. Kaiser Permanente also tried to improve patient medication adherence by using telephone follow-up, free walk-in blood pressure checks, and careful patient education. And finally, on a regular basis, they provided performance feedback at both the clinician and the clinic level. So, we clearly have the tools to improve hypertension control and reduce the multiple cardiovascular and renal complications of this most important disorder. We simply need to implement them.